Hi everyone, we are group 1 and we're going to be talking about medulloblastoma today. So medulloblastoma is an embryonal tumor that develops from fetal cells that remain after birth. This pathology rarely occurs in adults and it is the most common childhood malignant brain tumor, with the majority being located within the cerebellum. The incidence of medulloblastoma is 5 cases per 1 million individuals, with the median age of diagnosis being 6, and the peak incidence is from 6 to 8 years old. So some signs and symptoms include nausea and vomiting, lethargy, headaches, mostly in the morning, and ataxia, and this can be due to that CSF buildup. And if it does spread to the spine, this can affect the bowel and bladder habits. It can cause weakness or numbness of the extremities, and it can also cause pain within the spinal area. Now, in order to diagnose this pathology, there's firstly a physical exam that looks at gait, coordination, finger to nose testing, and the Romberg test, which looks at one's balance. In terms of imaging, a CT is usually obtained first, as most patients present to the emergency department. And on the CT image, medulloblastomas will appear hyperdense on the scan. Now, an MRI is then taken of the CNS compartment, the brain and spine, and it's used to evaluate metastatic spread, and this is the gold standard. This is performed pre-operatively, and then another scan is performed post-operatively to assess any residual tumor. MR spectroscopy can also be used, and it can help differentiate between medulloblastomas and other tumors of the posterior fossa. Now, in terms of staging, a lumbar puncture is performed 10 to 14 days post-operatively for CSF cytology, and a definitive diagnosis is done by assessing the tumor tissue obtained through surgery or biopsy. Now, this image here just showcases an MRI scan with contrast, and it shows lesions within the cerebellum and also metastatic spread to the spine. And in terms of treatment, the current standard of care is surgical resection with craniospinal irradiation and chemotherapy. Radiation is given to those that are greater than 3 years old, and it's avoided for those children under 3 due to the damage it can cause to developing brain cells. So average risk patients are going to receive around 23.4 gray with a boost to the tumor bed, and high risk patients are going to receive around 36 gray with boost to metastatic sites. Chemotherapy is also commonly used, and this includes cisplatin, carboplatin, and vincristine. And then this image here just showcases how a patient would be positioned for radiation treatment. And see, with that mask, it can definitely make it quite difficult for pediatric treatments. Now, in terms of prognostic indicators, it's based upon age, pathological subgroup, and surgical margins. There are 4 different types of subgroups, and the ones with the best prognosis is WNT activated, and the one with the lowest prognosis is group 3. Some other indicators include children who are under 3, they have a lower rate, and if there is metastatic spread, that also lowers the prognosis. And in terms of surgery, if a partial resection was done, it has a lower prognosis compared to a complete resection. And now this graph here just showcases how common each subtype is, with group 4 being the most common.
Moving on to imaging, the MRI evaluation of medulloblastoma is typically performed using either a 1.5 Tesla or a 3 Tesla scanner. A 3 Tesla scanner provides a higher SNR, and that improves the image clarity and the spatial resolution. That's good for neurological imaging, where distinguishing small lesions or subtle differences in brain tissue is important. And other equipment includes an IV contrast injector, immobilization, sedation, and the appropriate size coil.
So moving on to our planes of imaging, I just have 3 different images here of the same scan and same patient. Just a quick review on the planes, different planes of the human body. So on the first image on the left, we can see a transverse cut of the brain, which separates the top and bottom, or superior and inferior aspect of the patient. On the middle here, we have a coronal slice, which separates the front and back, or the anterior and posterior. And finally, the last image on the right shows a sagittal slice, which is the left and right, separates the left and right. And then when it comes to imaging for medulloblastoma specifically, MRI is considered the gold standard in diagnosing pediatric population specifically, because it provides better soft tissue contrast compared to other imaging modalities like CT, for example. And typically an MRI of the spine would be included as well to assess for metastases. Moving on to our T1 pre and post gadolinium contrast sequence. With T1 pre-contrast, we're using a short TR as well as a short TE. The short TR maximizes the T1 contrast, while the short TE minimizes the T2 contrast. And then typically on T1 weighted images, fat as well as white matter will appear as hyperintense or bright, fluid, and gray matter will appear as hypointense or dark. And then in terms of the actual tumor itself, the tumor may be hypointense or isointense. So on the top right image here, we can see a transverse cut of the brain, and we can see a mass here that seems to be hypointense compared to the surrounding brain tissue here. And then on T1 post-contrast, the tumor may show enhancement. As seen on the bottom right image here, we can see that same tumor just showing some enhancements after the gadolinium has been injected to the patient. And then as a quick review, T1 contrast is basically achieved when the longitudinal magnetization vector is recovered from transverse to the longitudinal plane. So that is because the protons release their energy onto the surrounding tissue and realign themselves with the main magnetic field. And then with T2 contrast or T2 sequence, we're acquiring those images or those scans with a long TR, and that maximizes our T2 contrast, and long TE, which minimizes the T1 contrast. So it'd be the opposite of T1. Fat will appear as isointense to a hyperintense. Fluid will appear as hyperintense. White matter will appear as hypointense. Gray matter will be hyperintense, and then the actual tumor itself may be isointense or hyperintense. So as you can see on the image on the right here, we have this relatively large tumor that shows area of hyperintensity as well as areas of isointensity. Yes, it's really well demonstrated on this T2 sequence. And then it would basically be with T2, it's basically the loss of transverse magnetization, which is because the protons, they gradually start to dephase once the RF pulse is off.
One crucial MRI sequence used in the evaluation of medulloblastoma is diffusion-weighted imaging, or DWI for short. And that relies on the detection of the movement of water molecules within the tissues. And in malignant tumors like medulloblastoma, the cells are more compressed, and so they have less extracellular space. That restricts the water diffusion and causes a reduction in water molecules. So that leads to a higher signal intensity on diffusion weighted images. And using DWI can help differentiate medulloblastoma from other posterior fossa tumors, such as ependiomas. And DWI is currently used to assess the features of a tumor, its response to treatment, and the odds of recurrence. And another key sequence for brain tumor imaging is fluid attention inversion recovery, or FLAIR for short. It is a T2 weighted sequence that suppresses signals from CSF, and long TR, long TE, and TI removes the signals from the CSF, but also preserves sensitivity to the tumor volume. And in FLAIR sequences, medulloblastoma typically exhibit a hyperintense signal. So this can help to show the size of the tumor and any abnormalities in the area, such as edema.
Okay, so next we're going to talk about some of the safety, patient prep, and imaging considerations that must be taken into account. So as we know, medulloblastoma most commonly affects the pediatric population, which is why there are some special considerations when scanning these patients. The enclosed space and loud noises of the machine can cause severe anxiety in some children, as it does with some adults. Some strategies that can alleviate some of their stress include allowing a parent or guardian to remain in the scan room, playing music or a movie to distract them, maintaining constant communication over the intercom, and providing hearing protection. Children, especially those under age 6, are not likely to remain still for the lengthy duration of the scan. Some children may require sedation or general anesthesia to remain calm and still. In general, individuals with medulloblastoma are likely to have increased intracranial pressure, which may affect their ability to lay flat for extended periods of time due to discomfort. In order to obtain a scan that is both comfortable for the patient and provides us with good image quality, positioning pads and straps are placed around the patient's head and along their body, given that the spine is also likely scanned. So some general safety concerns include the possibility of projectiles from IV poles and sedation monitoring equipment, as well as contrast injectors that may be in the room during the scan. Leads may also be placed on the patient's chest to monitor patient's heart during sedation or general anesthesia, and these leads may lead to RF burns. Multiple medulloblastoma patients will have shunts placed during surgical removal of their tumor to decrease the cerebrospinal fluid and allow for drainage of the CSF. Although many of the shunts are non-ferromagnetic, certain types contain metallic components. And just to note, many of these items on the screen here are MR conditional and must be checked by the screening technologist prior to entry into Zone 4, and many safety considerations must be taken.
Moving on to contrast, gadolinium-based contrast agents are paramagnetic, meaning they have positive magnetic susceptibility. This will improve T1 relaxation and shorten T1 recovery time. This will produce a heterogeneous contrast enhancement, which is helpful in defining the tumor extent. We can see on our images on the right that we're able to clearly differentiate the tumor from the surrounding normal gray matter. In typical brain MRI scans, we're not able to use contrast as they cannot pass the blood-brain barrier. However, medulloblastoma tumors disrupt the blood-brain barrier, which allows us to use those gadolinium-based contrast agents. This will increase signal intensity and overall visualization. In terms of protocol, gadolinium will be administered with an IV catheter at a dose of 0.1 micromoles per kilogram. However, in some cases, like metastatic lesions or recurrent tumors, they may be non-enhancing. This means that when we use the typical T1 post-gadolinium scan, we're not able to properly detect the extent of the tumor. Medulloblastoma tumors are hypercellular and restrict water movement, meaning they will appear hyperintense using DWI. We can see on our images on the right that our post-gadolinium scan did not pick up that lesion. However, our DWI shows it as pretty hyperintense. This is also beneficial for detecting leptomeningeal spread. Our primary concern for artifacts is emotion or ghosting artifacts due to the pediatric population of this tumor. Typically, we're only concerned about physiological movements like eye movements or breathing. However, there's an increased risk for voluntary movement due to the fear or anxiety that children might fear from the unfamiliar or confined environment of an MRI scanner. Additionally, brain scans can take upwards of an hour, and it might be challenging for children to lay still that entire time. Ghosting and motion artifacts are caused by the difference in amplitude between each repetition time. In terms of corrections, our first correction would be to swap the phase encoding. This repositions the artifact so that the area of interest can be visualized. While it does not reduce or get rid of the artifact, swapping it to a longer axis will help improve visualization and image quality. However, it might make the treatment time be a little bit longer. Alternatively, we could use parallel imaging. This decreases the case sampling to speed up acquisition time and hopefully reduce the need for sedation. And then the signals are reconstructed using algorithms so that shorter time doesn't decrease image quality. As we can see by our images, when our total acquisition time is shortened and our speed is doubled, we still have a very similar image quality present.
Thank you for listening to our presentation, guys. We have a link to a Kahoot just over here to test your knowledge.